Thank you. Thank you, Andrea. Thank you. Good evening, everyone, colleagues. It's really a pleasure to be standing in front of you to talk about the second pillar of our MMV strategy. I think everyone in this room knows about SMC. I'm part of that generation. When I was growing up in Africa, we used to get, at some time, one tablet at home. We used to get one tablet on our plates every Friday, if I recall, to prevent malaria before eating. So you take your tablet, if not, you are not given a meal. So that's how it was, and that was those days, chemoprophylaxis. Then at some point it stopped, and it went quiet. A few years ago, about 15 years ago, some new evidence led WHO to recommend now again chemoprevention using drugs in high, medium transmission areas. And several of these recommendations were published, but one of them, which is the one about SMC, picked up, and today it's a wide success that no one can be disputing. And in 2023, last year, we achieved to cover 53 million children with SMC. Though at the beginning, the estimates of SMC in total were 39 million only. So very, very basic estimates. I'm talking about all this because all this momentum behind SMC led WHO to, led the researchers first to look at other potential opportunities of prevention, and finally generating evidence and leading WHO to review their recommendation. And 2022-2023, they were revisiting SMC recommendation, extending the age or opening the age, allowing new recommendation, intermittent preventive treatment in school children, revisiting intermittent preventive treatment in infant, then IPTP is still there with community IPTP and so on. All these strategies to say that prevention using drugs today is very central in the tools that are used to combat malaria, and inevitably that should have a very key position in a strategy for an organization like MMV. So it's becoming today, just to talk a bit about integration, SMC and prevention, chemoprevention in general, it's so appealing today that talking about integration, it is used now as an entry point to tackle other diseases. So moving from the vertical approach, malaria, today we are using in Niger, for example, SMC to diagnose severe malnutrition and take actions. And these are things that we'll be thinking about to see how we can use this entry point of prevention to integrate more other disease related to childhood. Now, IPTSC, PMC, evidence are being generated. They are recommended, but they are not widely implemented yet. We should build from the success of SMC to make those other interventions as widely implemented as SMC. This is something we are doing, as usual, in partnership with all the partners, implementing partners, funding partners, the research, and so on. And that led us to lead at some time the creation of the SMC Alliance, and building from the words from Dr. Daniel about putting multidisciplinary people together. I think we succeeded with SMC Alliance, and we want to build now from SMC Alliance to create a sort of platform regrouping all the chemoprevention intervention in children. And this is part of our strategy and what we'll be doing in the next 5 years to make sure that all children eligible for a chemoprevention intervention, wherever they are, can get this intervention. And of course, we are doing that in partnership with our manufacturers, this needs drug and sometimes huge volume of drugs. I've been talking about 53 million children, and those 53 million children will need 4 or 5 doses of drugs. So definitely the capacity production of the manufacturers needs to be going alongside with that. Now, it's not perfect. There are tools that are there. MMV is focusing on drugs, certainly, but we all know they are malaria vaccines now. And we need some studies have demonstrated synergies. Now we need to see how the drugs that are coming from MMV and the partners can be used alongside on a more efficient way on the field to achieve better results again. Because synergies have been demonstrated to be better than each of the tools used alone. So this is something that also will be looking on the implementation side, how is that feasible? And of course, advocating because we are in an environment where the resources are becoming limited. So we have to work to see how optimally we can deploy all those resources to be the most efficient possible. Cost effectiveness, of course, will contribute to that. Now, in the story, Viveka just talked about resistance. It's not just about curing patients, because most of the drugs that are used for chemoprevention now are very old drugs. So there will be a need to find a replacement solution. This is the work of MMV, to look at innovations and so on to anticipate on resistance. So in the pipelines with our colleagues from R&D, there are options in the pipeline that are coming, and we should be ready in the access department to prepare the ground to accept those new innovations. So as I was talking about manufacturing, there will be a need to improve availability, accessibility, and affordability, widening the options of manufacturing. And with Africa CDC today, there is a motto and there is a motivation about developing local manufacturing. And in this perspective, we have been starting the work. And it is therefore my pleasure to introduce Mr. Palu Danani, who, with 40 years of experience in the pharma, he's the managing director and the owner, the founder of Universal Limited in Kenya, based in Kikuyu in Kenya, with whom we managed to get to pre-qualification, SP and SP amodiaquine. But it's many years of experience of pre-qualification, and we would like him to maybe share the experience of pre-qualified manufacturing from based in Africa and working for African and working on products for Africans. Welcome.
Thank you, Andre. Well, it's a pleasure to be standing in front of all of you, and thank you for inviting me to be presenting today. We were the first African manufacturer to get pre-qualified for SP and SPAQ, but that's just last year. But we have had the pre-qualification status for the past 11 years. So it's not something new that's sort of a hit and run thing. It's a sustainable model. And it's not only malaria, but we also have products including AL in the malaria strength, and we also have an HIV product, the first line treatment for HIV, which is pre-qualified as well. Just to maybe mention a few things, I think we heard that malaria, really, the major problem is in Africa, but we don't have enough manufacturers in Africa. So in the journey we went through with MMV, we just cannot say enough thank you, that with the funding that you gave us, it took us to a level that really helped us, not only the funding, but we got a lot of technical assistance, help, different ideas. Like MMV suggested, we should have a pink tablet, because it's really for pregnant women, and it was really a challenge to convince WHO with a pink color. But we fought the journey together with MMV, and thank you, that was good advice. And this was, Universal Corporation is based in Kikuyu. We are part of the Strides group, based out of India. And in this particular product for SP, we partner with a company as well from Rena Exports from India. As I mentioned, we have a lot of advantages of African manufacturing. I think I'm not a technical person, so I'll not go into any clinical data and all that. But as an African manufacturer, I think COVID taught us a lot of lessons. During the COVID time, there were certain items which the donors were buying from us, and 19 countries out of the entire Africa on the continent, which were through the donors, we were supplying from Kikuyu. Whereas all the countries that were relying from imports had all shortages, huge shortages of that product. So it's always advantageous to have product manufactured near where the problem is. So I guess it's a good start again. Thank you very much for that help and assistance. We cannot, as an African manufacturer, I think we also have challenges. Everything that we manufacture, all the raw materials, including majority packaging materials, are still imported. And the reason being that there is no domestic demand to put up plants for that. So eventually, everything will be backward integrated, and those will definitely reduce a lot of costs and timely supplies. Even right now, there is no challenge in timely supplies. We have proven that we supply on time, being out of Africa. There were cases where people were saying it's difficult to manufacture in Africa. Challenges, maybe questions were coming about our pricing, but we are not expensive. It's a myth. Yes, we'll be slightly more expensive, but due to several factors, we don't enjoy any export benefits like other countries do give export benefits to their manufacturers, which in Africa we don't expect. We have some taxes in certain countries, which makes it even more expensive. And generally, the cost of manufacturing is 6 to 7% more expensive, but it's not 6 to 7% on the selling price, on the cost price. So overall, depends on the product, how fast it's required, whether we airlift the material or not. It cannot be more than 15% and as low as 0.5% difference. So it's a myth that they are expensive. In certain cases, there are procurement agents who have bought at a higher price than what we have been supplying from Africa at. Challenges, I think, if as a group we could also think about how to facilitate registrations, because that's a big challenge on the continent. We have 52 regulators. So if you have a product, we have to convince 52 regulators. So I think that is one assistance from the group if we can get that, and especially when the product has been PQ'd, it should be quickly adopted. There is a collaborative procedure at the WHO, but I think it's still a bit slow. It needs a bit more fast tracking on that, because every country wants to be autonomous, which is good, but some assistance would be great in developing African manufacturing. When you have a population of, let's say, 15, 20 million in Rwanda or 50 million in Kenya, the volumes are not enough to make a big plant and make it more competitive. So when you get the whole, the continent at large, clearly prices can fall, or I'm not saying fall, but we will be more competitive than we are today. So please, let's not think that we are not competitive. We are definitely very competitive. Capacity. I think I heard you say capacity. Capacity is relevant to the market size that you go for. I mean, just as an example, just one company, that is us, we have a capacity of 3 billion tablets a year. So I think it's reasonable size capacity compared to the orders which we have not received till now. We have just been awarded by the Global Fund the first time antimalarials and HIV products. Let's hope that with that, capacity should not be an issue. And obviously it takes time to expand, but many manufacturers, and I think now with the donor world talking about African manufacturing, is clearly going to see a lot of investments coming in through, and a lot of factories have started coming in already, including many expansions on people who are already existing. One request also we have is maybe governments, like Kenya government really has supported local manufacturing now. There's a list of products that they only will buy from the local producers. So like that, we expect African governments to be also supportive, and that's one message maybe we could take through the ministers for health or the heads of state. And somehow help us reduce on imports. Like if you take example of Nigeria, Bangladesh, it's really helping local manufacturing grow. And I think there is enough evidence to show that whatever is manufactured locally, accessibility, availability, affordability will all be there as part of it. I still have time. Anyway, I think I have a lot of other things I can discuss, but I'll just stop here. Thank you.